Good morning, guys. Today we will talk about pneumothoraxes. I think it's interesting topic because pneumothorax is not hard to treat if you know how we need to treat it and how we need to um, search in pneumothoraxes. Uh, when we talk about pneumothoraxes, we need to understand that it is the air in the lung cavity. Yeah, in this picture you see a schematic picture of air, yeah, in the pleural cavity, and you see what happened with lung when we have any air in the pleural cavity. Under normal conditions, the in pleural cavity we haven't got air. Also, the intrapleural pressure during the respiratory cycle is mainly negative, and it is 3 or 5 centimeters of water column atmospheric pressure. What do you need to know when we talk about lungs and when we talk about breathing? The sum of all the partial pressure of gases in the capillary blood is approximately 93 and 9 kilopascals. This is 706 millimeters of Hg. So, the movement of gas from the capillaries to the pleural cavity requires an intrapleural pressure decrease 54 millimeters Hg below atmospheric pressure, which almost never happens in real life, so the pleural cavity is free of gas. The presence of gas in the reason of gas in the pleural cavity is can be three three reasons would lead to pneumothoraxes. The first one is direct communication between the alveoli and the pleural cavity. For example, we have lungs, yeah, and there we have alveoles, and something happened with alveoles. For example, it's damaged and we have a hole what lead to pneumothoraxes. This hole of air and pleural cavity. The second one it is a direct communication between the atmosphere and the pleural cavity. Next situation, yeah, we have a patient and he have a knife, yeah, for example, and do a perforation of skin, yeah, do a wound, and we see this hole what can lead to pneumothoraxes. And the third one, the presence of gas forming microorganisms in pleural cavity. It means that some microorganisms can ferment a gas intrapleural cavity. Yeah, and for example, we have situation when these microorganisms lead to pneumothoraxes. The flow of gas into the pleural cavity continues until the pressure in it becomes equal to atmospheric pressure or until they close the hole. Wolf mechanism. Sometimes pathological hole passes air into the pleural cavity only during inspiration, only in breathing, inspiration. During exhalation, exhalation, inspiration, exhalation. It prevents the evacuation of air. As a result of such clauses and prevents the evacuation of air, as a result of such evolved mechanism, the pressure in the pleural cavity can significantly exceed the atmospheric pressure, and we call this situation a tension pneumothorax. High intrapleural pressure leads to displacement of the mediastinal organs. Sometimes we see a flattening of the diaphragm and compression of the unaffected lung. The consequences of the process are a decrease in venous return, a decrease in cardiac output. It leads to hypoxemia, which leads to development of acute circulatory insufficiency. Classification. All pneumothorax can be divided into spontaneous, when we don't associate it with any obvious cause, and traumatic, when we associate with direct and indirect chest trauma, and iatrogenic, when we associate with medical interventions. In turn, spontaneous pneumothorax is divided into primary, when mm, when a patient haven't got any pathology or any disease of lungs. And secondary, when patients have some pathology of lungs. And there you see reasons of secondary spontaneous pneumothorax. The most common causes of respiratory tract disease infections. When we talk about respiratory tract disease, we talk about chronic obstruction disease of lungs, cystic fibrosis, severe exacerbation of bronchial asthma. Next big group, it's infectious disease of the lungs, for example, pneumothorax, carinea pneumonia, tuberculosis, abscess. Next groups is interstitial lung disease. There we talk about sarcoidosis, idiopathic pulmonary fibrosis, histiocytosis, lymphangioliomyomatosis, lymphangioliomyomatosis, yes, systematic connective tissue disease, rheumatoid arthritis, ankylosing spondylitis, polymyositis, dermatomyositis, systematic scleroderma, Marfan syndrome, Ehlers-Danlos tumor, Ehlers-Danlos tumor syndrome. Sometimes we can go talk about cancers, sarcoma of a secondary spontaneous pneumothorax. Sarcoma. Diagnostics. When we talk about anamnesis, we need to understand that all what happened, pneumothorax happened acute, this acute situation, yes. If it's a reason, if it is a mechanic, traumatic pneumothorax, patient have trauma. If it is iatrogenic, we understand that something can happen. Yeah, if we do, for example, pleurocentesis for patient, we understand that if after pleurocentesis he have pneumothorax, it's our complication. And if patient have a spontaneous pneumothorax, it happened acute, yeah, and he have no reason of this situation. Often it's not associated with physical activity. And your survey of patient should include questions about smoking history, episodes of pneumothorax, and the presence of lung disease. And not only lung disease, but all disease, all chronic disease what patient have, you need to ask too. Complaints of your patients. The leading complaints are chest pain and shortness of breath. The pain is often described by the patient as sharp person danger. Increases during inspiration, can radiate to the shoulder of the affect site. The severity of dyspnea is associated with the size of pneumothorax. With secondary pneumothorax, as a rule, there is more severe dyspnea, which is associated with a decrease in the respiratory reserve in such patients. Dry cough, sweating, general weakness, and anxiety may occur less frequently. The symptoms of the disease most often weaken after 24 hours from the onset of the disease, even in the absence of the therapy, and maintain the same volume of pneumothorax. Physical signs: restriction of the respiratory excursions, weakening of breathing, tympanic sound with percussion, tachypnea, tachycardia with a small pneumothorax. A physical examination may not reveal any changes. Tachycardia more than 135 per 1 minute. Hypotension, paradoxical pulse, swelling of the cervical veins, and cyanosis are signs of a tense pneumothorax. possible subcutaneous emphysema. Laboratory tests. In analysis, we always see hypoxemia. Arterial blood gases decrease. Less than 80 millimeters Hg. It's observed in 75% of patients with pneumothorax. The presence of background lung disease and the size of the pneumothorax are closely related to changes in the gas composition of arterial blood. The main causes of hypoxemia is collapse and decreased ventilation of the affected lung with preserved pulmonary perfusion. Hypercapnia develops rarely, only in patients with severe background lung disease. Respiratory alkalosis is quite often present at VSP, less than 55 millimeters Hg. This observed in 15%. Radiography. I think that radiography is the most needed when we talk about pneumothorax. You always will see in X-ray pneumothorax. If you want to remember how we need to look on X-ray when we talk about pneumothorax, you can tap on this video. Radiography of the chest confirms the diagnosis. It is necessary to conduct a chest X-ray is anteroposterior with the patient in the optimal projection is anteroposterior with the patient in an upright position. Signs of pneumothorax in X-ray. First of all, we see a thin line of the visceral pleura. This one, we see thin line. A common finding in pneumothorax is the displacement of the mediastinal shadow in the opposite direction. In this X-ray, I don't see a displacement of the mediastinal shadow. Since the mediastinum is not a fixed structure, even a small pneumothorax can lead to displacement of the heart, trachea, and other elements of the mediastinum. So a contralateral mediastinal shift is neither a sign of the severity pneumothorax nor a sign of a strained pneumothorax. 10 or 20% of pneumothorax is accompanied by the appearance of the small pleural effusion within the sinus. 1 second. There in X-ray we don't see these infusions. In the absence of signs of pneumothorax according to the radiograph in the anteroposterior projection, but in the presence of clinical data in favor of pneumothorax, radiographs are shown in the lateral position of the site. The cubitus lateralis, which allows to confirm the diagnosis, is an additional 14% of cases. Some guidelines recommend that in difficult cases, radiography should be performed not only at the high of inspiration, but also at the end of exhalation. However, as recent studies have shown, expiratory images have no advantage over conventional inspiratory ones. Moreover, a vigorous exhalation can significantly worsen the condition of a patient with pneumothorax and even lead to asphyxia, especially with tense and bilateral pneumothorax. Therefore, radiography at the height of exhalation is not recommended for the diagnosis of pneumothorax. The next one, signs of pneumothorax on X-ray, if patient can just lay down, horizontal position. Radiographic sign of pneumothorax in a patient in a horizontal position is a sign of a deep sulcus, deep sign. Which is especially noticeable when compared with the opposite side. Pneumothorax in a patient during mechanical ventilation, a sign of deep sulcus, where white arrows for the diagnosis of small-sized pneumothorax. CT is more reliable method compared to radiography. The sensitivity of CT in the dissection of pneumothorax after transthoracic lung biopsy for the differential diagnosis of large emphysematous bulle and pneumothorax, the most sensitive method is CT. CT indicated to determine the causes of secondary spontaneous pneumothorax. Sometimes we need, not sometimes, always we need determining the size of a pneumothorax. The size of pneumothorax is one of the most important parameters that determine the choice of treatment tactics. The most widely accepted formula is light. Formula is called light. Based on the position that the volume of the lung and the volume of the hemithorax are proportional to the size of their diameters raised to the third power. The size of the pneumothorax, according to the light formula, is calculated as follows. The volume of the pneumothorax 1 minus dl. dl is the diameter of the lung. dh is the diameter of the hemithorax. CD. Spiral computer tomography, MSCT, of the chest plays a major role in determining the causes of pneumothorax and the differential diagnosis of another disease with other pathology. CT should be performed after draining the pleural cavity and spreading the lung as much as possible. In CT, the following signs are evaluated for example, the presence of absence of changes in the pulmonary parenchyma, such as infiltration, disseminated process, interstitial changes, unilateral or bilateral bullous changes, diffuse emphysema. Relapses of pneumothorax. Relapses is the development of rapid pneumothorax after primary pneumothorax, are one of the important aspects of patient management. Relapses, as a rule, do not complicate the course of traumatic and iatrogenic pneumothorax. According to the analysis of the literature data, the frequency of relapses in 10 year after pneumothorax range from 16 to 52%. However, in 30%, the main number of relapses occurs in the first 2 years after the first episode of pneumothorax. After replace of pneumothorax, the probability of subsequent relapse progressive increase. The main risk factors for relapses in patients with spontaneous pneumothorax are the presence of pulmonary fibrosis, age over 60 years, high growth, and low nutritional status of patients. The presence of subpleural bulla is not a risk factor for relapse. Differential diagnosis. With pneumonia, pulmonary embolism, viral pleurosis, acute pericarditis. I think that third it's a pleuritis, acute coronary syndrome, and broken ribs. Treatment. First of all, we need observate and do oxygen therapy. We can do a simple aspiration, installation of drainage tube, chemical Pleurodasis, and surgical treatment. Observation and the oxygen therapy. It's recommended to limit yourself only to observation. When pneumothorax of a small volume with a distance between the lung and the chest wall less than 1 cm, we don't do a Pleurodesis. The resolution rate of the pneumothorax is 152% of the hemithorax volume with 24 hours. Thus it will take approximately 8 or 12 days. For all patients, even with the normal gas composition of arterial blood, as shown the appointment of oxygen 10 minutes through a mask, but a positive effect is also observed when prescribing oxygen through cannulas. Drainage of the pleural cavity. Drainage of the pleural cavity. Thoracostomy with drainage tubes has shown the failure of simple aspiration in patients with PSP, pneumothorax, at VSP when the distance between the lungs and the chest wall more than 2 centimeters in patients with dyspnea and older than 50 years. Choosing the right size of the drainage tube is very important. Patients with PSP, pneumothorax, are recommended to use small diameter tubes of 10 or 14 French. The use of tubes with a diameter 16 or 22 French is recommended for stable patients with WSP, with do not plan to undergo a ventilator, for patients with pneumothorax developing during a ventilator who have a very high risk of forming a bronchopleural fistula. The installation of a drainage tube is more painful procedure compared to pleural punction and is associated with complications such as penetration into the lungs. Drainage of the pleural cavity leads to the expansion of the lung. The use of a suction is not necessary when draining the pleural cavity. Currently, the most accepted method is the connection of the drainage tube to the water lock. There is no data on the advantage of the Heimlich valve Heimlich lock. There is no data on the advantage of the Heimlich valve over the water lock. It's recommended to resort to the use of suction system if the flow of leakage. Chemical pleurodesis. One of the most leading tasks in the treatment of pneumothorax is to prevent repeated pneumothorax relapse, but neither simple aspiration nor drainage of the pleural cavity can reduce the number of relapses. Chemical pleurodesis is a procedure in which substances are injected into the pleural cavity that lead to aseptic inflammation and adhesions between lung and pleura. Chemical pleurodesis is indicated in patients with the first and subsequent WSP and in patients with the second and subsequent PSP, as it prevents the occurrence of relapses pneumothorax. Chemical pleurodesis is usually performed by introducing doxycycline or tackle suspension. At least 25 milliliters at least of 1% lidocaine solution after the introduction of the sclerosing agent. The drainage tube is blocked for 1 hour. Emergency surgical care for spontaneous pneumothorax should be directed first of all to decompression of the pleural cavity and prevent of respiratory and circulatory disorders, and only then to perform a radical operation. Surgical treatment of pneumothorax. When we talk about goal of surgical treatment, it is resection of bulls and subpleural blebs or bubbles suturing of defects of lungs, and Pleurodesis. Indications for surgical treatment: absence of lung expansion after drainage for 5-7 days, bilateral spontaneous pneumothorax, contralateral pneumothorax, spontaneous hemopneumothorax, relapse of pneumothorax. No, you see all of this in this picture. Urgent situation. When we talk about tension pneumothorax, we need to do a thoracentesis. We can use a needle or cannula of venipuncture no shorter than 4 and 5 centimeters in the second intercostal space along the mid-clavicular line, even if it's impossible to confirm the diagnosis with radiography. Patient education. After discharge from the hospital, the patient should avoid physical activity for 1 month and air travel for 1 month. The patient should be advised to avoid changes in the barometric pressure. The patient should be advised to stop smoking. Father maintains after the resolution of the pneumothorax is a chest X-ray. Consultation with a pulmonologist at 7 or 10 days after discharge from the hospital. And today that's all. Thank you very much for your attention. We'll see on the practice. Bye bye.